All right, it's recording. So thanks, guys, for coming.
Say hi, welcome to my channel.
Welcome to my channel. Yeah, no. Nope. It's fun with flags. So today we're going to talk about the Germany flag. No. So, how's everyone feeling overall?
Awful.
Awful. Okay, good.
Dead.
That's what I kind of want to hear.
Insecure.
Insecure is a good term.
Unconfident.
How about rest days? Have we at least taken one?
No, it's not on the calendar to take a rest.
Well, it's not on your calendar, but I want to make sure that you guys are getting a little bit of your own time. So please.
My rest days when I work.
Your rest days when you work? Okay, that'll work.
After exam, we'll have.
After the exam. I told you the layout of the place where it's at. So you get the, they got the coffee bar going in and the regular bar going out. So, but yeah, honestly, you guys are supposed to feel like you're exhausted. That's kind of what it is, right? And you'll feel even worse coming out of the test, just because that's what everyone does. I usually get worried if people come out of the test and say, "Oh, I feel great." Then I'm like, "Oh boy, that's not a good sign." So it's just the way it is, right? So make sure that you're giving your brain a little bit of a break, because you do need some functional brain power by the time you get there. And make sure that last day, like I said before the test, do not study, please. I put that on the calendar for you not to do study. Get together as a group and go downtown and walk the strip or something. Or go hiking. That's what the last group did. They went out to Red Rock and went hiking all day. So, and that took their brains off of it, and somebody sprained their ankle, so. That was another show me moment. Watch this, I'll climb the rocks. So, got a list of some of the stuff that people wanted to cover. And Kevin added brachial plexus to it as well. So we'll try to see what I can do. I didn't prep for that, so we'll see how I do with that one. Pediatric reflexes was the first thing that people requested. So, who's having trouble with pediatric reflexes at this point? Anyone in here? It may have been Paige that asked for that, so I'm not sure. Well, pediatric reflexes, I put the pages up here that have pretty much everything pediatric-wise in your two books. What I'd cover on that specifically is don't dig, if there's so many pediatric reflexes, right? Just that whole list just keeps going. If you look 0 to 6 months, 6 to 12 months, 12 to 18, it just keeps going, right? What ones do you think are important to know? ATNR, STNR. Those are the two big ones, right? ATNR, STNR. Because those will eventually come back here into our synergy patterns, right? So that's why you kind of have to know them as a kid and then know them why they're abnormal as an adult, right? What other primitive reflexes maybe? Moro, right? Moro's the big one, right? Gallant. And suckling reflex or rooting reflex, right? One's rooting reflex. What's that for? What do they, if they don't have that, what don't they do? They go hungry. They don't feed, right? And also just take a look at the APGAR if you haven't looked at the APGAR yet. Okay, the APGAR is on page 276 of Score Builders. What's the APGAR for? Because I've seen a couple questions pop up about APGAR. See where the baby's at when? At birth. Yeah, right? You don't have to know it totally, but the main thing they're looking for is do you understand what APGAR means, right? So what's APGAR mean? A is for appearance, P is for, okay, G is for grimace, right? Facial expressions. A is for, yeah, muscle movement, activity. And then R is for the most important one, breathing, respiration. Are they breathing, right? So if you know what those mean, you can answer an APGAR question. Because most of the time it's going to give you something saying that this is absent. And if you know that, they're not scoring very high. How does a baby develop? Head to feet or feet to head? Okay, heard it what?
Head to feet.
Yes, cephalodicotyl, right? So when the baby's little neural tube that grows out. So that's the other one that might be on it. But the main thing you guys have to know, like I said, we covered most of them. Then the other two reflexes that are kind of important are palmar grasp and plantar grasp. Because palmar's going to allow them to do what? Grab things, move things, right? Function. And it's also eventually going to lead to standing up because they need palmar to grab a hold of something to pull themselves up. Right? And then plantar, if that doesn't integrate, every time they step on their foot, they curl up and they don't get a good grip. So they don't have anything to plant on, right? And then the other thing you might want to know about kids is the progression for walking. So how does the progression for walking go? Okay, what is crawling? What's crawling look like? What? Not on the knees. No. Crawling is army crawl. Right? Crawling, scooting with the arms. Right? Then what's the next step? Creeping. Now that's up on here. All fours, and then moves to creeping on furniture, which is what? Where they grab a hold of the furniture and do this thing, right? And then that leads to walking. So it's crawling, creeping, walking, right? So just make sure you know kind of the rotation of that. If they miss one of those milestones, is that bad? They go straight to walking. Yeah. Yeah, there's a lot of studies that show if they miss one of those if they miss creeping and go straight from crawling to walking, that they miss a lot of the functional upper extremity function. So then they have problems later in hand-eye coordination and stuff like that. So it's not always good for your baby to go, oh my God, my baby's 3 months and walking. On top of that, the baby's running around the house at 3 months, and right? So just make sure that's the main thing. And then what's the first sitting position they work on for babies? Yep, you're doing it. You're almost doing it. You're too tight. What's it called with their feet together and sitting up? Ring sitting. Ring sitting, right? What's the sitting we want them to avoid as babies and kids? W sitting, right? Why is that? What's that develop into? Hip dysplasia, right? Especially among who? Girls, yeah, right? Little girls will develop hip dysplasia if they W sit. Guys, not so much, and there's all kinds of reasons behind that, but also because of the way the hips are designed, right? Don't judge me, it's my one Coke. So that's the main thing with pediatric reflexes. Just, you don't have to know them all, but you definitely want to know the ones that are important. Like I said, the rooting reflex, your Gallant, your Moro, your ATNR and STNR are probably your most important, right? So when should ATNR be integrated by? By 6 months, right? So anything up to 6 months, if it talks, if the question saying baby is 5 months old, still presents with ATNR reflex, and you should be going down to the bottom, looking through the questions and looking for this is normal, right? If it says baby is 18 months and still presents with ATNR reflex, now you're going down looking through the questions for something that's abnormal, right? What does ATNR eventually lead to them doing? Rolling, yeah, right? And then STNR, when's STNR integrate? So ideally by 9 months is, I know the book says 6 to 8 months, but by 9 months is kind of what we want it by, right? So anything up to 9 months we would consider what? Normal, right? So that's the one thing, I save synergies for you, don't worry. So ATNR, STNR, so both of those should be integrated by 9 months, which means they should be pretty much ready to roll over and ready to push up into crawling. That's kind of what the goal is. What's Gallant? You stroke the side and what happens? They kind of rotate, right? When should that be integrated by? Yeah, by 3 months, right? Ideally by 3. Sometimes they say by 30 weeks. I think it's the one that the book says 30 weeks. But 3 months is definitely the goal, right? So what happens if they don't, what's the big problem if they don't integrate that one? What can't they do? What's that? Yeah, can't sit. Yeah, and the other big one is they develop scoliosis. Because what that means is the muscles along the spine aren't strengthening, right? And so they're going to kind of slouch to one side and going to end up with a scoliotic curve. And we know that the younger they are that they start developing that scoliotic curve, the more structural it's going to become, the less functional it is, right? So we want to make sure that you're not here. Palmer, when should that be integrated?
4 months.
Yeah, by 5, 6 months. 4 months is what the book says, but you definitely want it by 6. If not 6, you've got problems because at 6 we're starting to crawl. Or we should be at least. What about plantar? Yeah, so Palmer's about by 6. Good rule of thumb is about 3 months later. So by 9, plantar should be integrated, right? Because at that point then we're having problems. So either of those can interfere with standing and walking, right? Especially palmar or plantar grass, but palmar can as well because you need that grass to be able to pull the baby up, right? And also eventually they need the grass to hold what? Bottles, right? They can't self-feed if they don't develop palmar grass reflex. What's the major? What's our major disorder we treat of little babies in physical therapy? What's the common thing we see babies for? Babies. Torticollis, yeah, right. And that's usually going back to Gallant. A lot of times it'll go back to that reflex, and that's why they end up with torticollis, because they're sitting on one side and they're not getting that response kind of right. So, and torticollis is which muscle? Sternocleidomastoid, right? How do their heads go? If I have right torticollis.
Flexion to the right side, rotation to the left.
Yeah, so I'm looking like this, right? So that means you need to stretch me, flex other side, rotate the opposite side, right? And then get puked on because the baby's mad, right? Truth. Is there anything else you guys can think about at peds that you guys wanted to cover? And it doesn't seem like either of you guys, any people that wanted peds is here, so that was the main thing. Is you don't have to know all of the stuff about peds. Remember, how many questions is peds going to be about? About maybe 5 to 7. Right? So it's not going to be a total, because guess what we treat more of than kids? Adults. Right? And then peds are going to come back when we talk about pathologies, right? Talking about stuff like CP, muscular dystrophy. So there's only a handful of questions that are going to be on pediatric reflexes and pediatric growth. There's going to be more on pediatric pathology than there's going to be on pediatric growth. Does that make sense? Because pathology is a big part of your test. You look like you have a question. Yeah.
Why would Duchenne's muscular dystrophy, they put their hands in their legs? I remember you explained
Okay.
it one
Yep.
time.
So we're skipping it. Duchenne. That's good. No, just kidding.
Oh, sorry.
That's okay. No, Duchenne's. What? So she's asking, what's that called though? Gowers sign, right? Do you remember Gowers sign? Kids trying to get up, and how do we normally get up? We kind of like this, right? And we have to have a functional what to do that? Functional core, right? And whereas the kid with Duchenne's, I don't know if they can see me. That's too bad. They kind of have to work their way here and use one hand because they're lacking core. Because remember, muscular dystrophy goes core to distal versus ALS, which goes distal to proximal. Right? So their core is the first thing that wastes. And that's why they do Gowers. And that's the thing you should look for with kids. And that's usually what your question is going to be if you get a question about Duchenne's. Is it's going to be about Gowers sign. Because Gowers sign is probably the most common thing you're going to look for. Anything else about peds or pediatric reflexes or pediatric pathologies you can think of that you need?
No, I think it's just more remembering like the integrations.
Right. And again, don't torture yourself on the integrations. Know your basic reflexes. And for the most part, when you get to stuff like integration, it's going to be common sense. They're going to have questions that may say that when should a baby walk by, and you're going to be looking down through the questions, and it's going to be like 2 years to 3 years. You know, you go, nope, that one's out. 1 month to 3 months, nope, that one's out. You'll be able to get it down to 2 answers. Right? So don't totally freak out about studying everything in depth in peds, is what I'm saying. Although I consider peds important, it's not the most important for your tests. Are you okay on that one though? Alright, so let's mark that one off. Synergy patterns. Who's freaking out about synergy patterns? I know a couple of you. Okay, good. So,
And are they the same as contraction patterns? Contracture?
synergy patterns will lead to contraction patterns.
Okay.
Yes. So, synergies there. I want to say it was the other book that had the better chapter. Let me look here real quick. Yeah, so for synergy patterns, I really like the chart in the Therapy Ed book on page 73. I really, really, really like that chart. I thought there was another one there. I thought there was another thing I scored, but I guess there wasn't. So our synergy patterns, first of all, our synergy patterns normal or abnormal?
No, they're
Normal at first, right?
Yeah, they're normal as a baby, right? And then they become integrated. That's what ATNR, STNR are. Those are synergy patterns, right? But do we have normal synergy patterns as adults? Yeah. What about walking? What happens with the upper extremities when the lower extremities move? Yeah, right? The reciprocal arm swing. That's a synergy pattern, right? And that could be an abnormal synergy pattern if, when the patient's walking, they're lacking arm swing, right? Does that make sense? So I really like the abnormal synergy pattern, like I said, the table 212. Which is worse, flexion synergy or extension synergy? Extension synergy, right? Extension is the worst of the two. That means that there's a higher level damage, right? Typically, where is that damage going to be occurring? In the brain itself, right? Because remember, the synergy patterns here are going to lead to your favorite two terms. Remember those two? Decorticate, into the core, decerebrate, celebrate. Right? So the E is the extension pattern, right? Decerebrate, and then you have the core. Usually, decorticate's usually spinal cord. Could be some brain, but typically it's not as bad as decerebrate posturing, right? If the patient ends up in decerebrate posturing and gets no therapy, what posture are they going to eventually end up in? So they start in decerebrate posturing. Where do they eventually always end up? Decorticate, right? Because eventually they do what? What happens to all their muscles? Yeah, they waste and then they start shrinking and contracting up, right? So eventually they'll end up in decorticate posturing because that's the same as what type of posturing? Think of a little baby, right? Fetal position. Because that's really what that is fetal position. So can we use synergy patterns to our benefit if they have them? So sometimes when we use abnormal synergy patterns, especially in getting a stroke patient or a spinal cord patient out of bed.
Is that part of Brunstrom?
That's part of Brunstrom's, exactly. See, you linked a couple. Right? So what they'll use is they'll use those abnormal synergy patterns. If I know that if I can get this patient to trigger ATNR, and I need to roll them to the left, if I extend their right arm, that left arm flexes up, and I can roll them now onto their left side. Right? So I'll have them put their arm around my neck, and I know if I put their arm around my neck, this arm's going to kind of roll up because of ATNR. And I can use that to roll them. Right? So we don't want to promote abnormal synergies, but we will use abnormal synergies. Does that make sense? So when we see the abnormal synergies, what kind of stuff might we want to do? How do we normalize them?
When you say abnormal, what?
Like where they're starting to go into an extension, so every time you push them up, they sit up.
Oh.
They're getting more a reflex. How do we fix that? What does Brunstrom talk about doing for it? Do you remember? I heard it what? Functional patterns, right? Yep, so we use what's our PNF, good. PNF, and we also use rubbing and stroking and brushing, right? Same thing with a baby. If we stroke them at one point, they do things for us. Guess what? When they're in an abnormal synergy, we're going to use the stroking and brushing in order to get them to do stuff we want them to do. Right? So we're going to use different techniques. What about if they're spastic with their synergy patterns? How do we calm spasms down? I see you doing one of them. Tapping's one of them, right? Pressure, deep pressure is the other one, and then there's one modality we can use. Not heat. Heat actually makes it worse for spastic. Cold. Yeah, specifically which type of massage? Ice massage. Good, right? Ice massage calms down spasticity. So we can use little ice cups and put an ice cup on, and usually what I find works well for me is I like using ice plus deep pressure. Because then I get a combination of them both. Tapping sometimes works. Tapping works a lot when I'm dealing with the quads and stuff like that. But for upper extremity and like trunk control, I find that ice and deep pressure works best, right? So you find me going into that extension synergy, right? Where are you going to put the deep pressure at? What muscles?
What?
Yeah, which back muscles primarily? The group.
Paraspinal.
Yeah, paraspinals, the erector spinae, right? So if you want to avoid it, where's most of that flexion extension occur at? Which part of the spine? Go. Lumbar, there we go. Come on, folks. It's not that hard, right? So if you want to avoid that flexion extension synergy, you're going to put a lot of deep pressure here in my lumbar region to calm those spasms down, right? What about if I'm getting a push to one side or the other? With lateral trunk flexion, where are you going to put the pressure at? What's that? QL could be a good idea, but if you get to QL, you're putting a lot of pressure through the ribs. But what about spine?
The left side.
Yeah, thoracic side, right? Thoracic region, right? Thoracic region is primarily responsible for this type motion, right? Because your lumbar vertebrae are too big to do that. And then the neck just depends upon where they are. If it's high up, if it's low up, right? If it's rotational, or if it's side bending, or if it's flexion extension. So that's the main thing with when you're dealing with synergies is you're dealing with some sort of either brain or spinal cord injury damage. And what you have to do is figure out, is it a normal synergy, such as gait with the arms, or is it an abnormal synergy? Most of the questions are going to be about which? Abnormal, right? Because normal is not going to present. The patient presents with reciprocal arm swing, which is normal synergy. It's just going to talk about reciprocal arm swing, and that's a normal synergy, right? What else do you have about synergies? What did you run into specifically that you had problems with?
Still don't understand that question. I don't remember which question it is.
Okay.
About putting your leg behind you and tapping it down.
Was that from the end?
Yeah, probably. I think therapy is the only one that really talks about synergies.
Yeah, there's not too much in core builders because, again, synergies is maybe going to be one or two questions, right? Because, I'm just warning you, it's only going to be about one or two questions about synergies. It's going to be more, when you're talking neuro, it's going to be more dealing with spinal cord injuries and how to treat a stroke, and stroke's going to be big because strokes we seem to be getting a lot more of lately. If you can find the question, I'll talk about it and let's see if we can figure it out.
Is it like standing, picking the foot up behind and slowly lowering one? Yeah. 80. It's on 553.
530?
553.
553.
Question 84.
Let's see. Five, 3. You said question 84?
Yeah.
Okay, PTA is working with the patient in the patient's home. The patient's being seen for right hemiparesis. Okay, so what's that mean, first of all? Right hemiparesis means right side's either A, knocked out completely, or it's got problems. Right, so don't always assume that hemiparesis means it's completely gone. It could just mean that it can't feel, too. Right? Physical therapy eval indicates the patient is demonstrating good recovery. Both involved extremities are categorized as out of synergy. The patient is ambulatory with small quad-based cane. Which activity is most appropriate in this stage of recovery? Okay, so here's the way I look at this question. I'm not even going to look at synergy patterns. I think I sent this answer to you as well, but I'm not even looking at this as a synergy question. What I'm looking at is patient is ambulatory with small quad-based cane. What kind of activity do I want to do with that patient? Walking. Any type of standing activity. Right? So I'm going down through my questions and going, okay, so 1 and 2 are out. Why are 1 and 2 out? Sitting in supine, right? Not going to help a patient walk, especially if they're already ambulatory. Now, if it said this was different and it said the patient isn't ambulatory and working on pre-gait, absolutely, the supine and sitting one could be a right answer. But they're already past the pre-gait stage. They're already into ambulatory with the cane. So then we're down to 3 and 4, which are standing, picking the foot up behind and slowly lowering it, standing, small range, knee extension movement to gain quadricep control. So does it anywhere in the question say the patient lacks quad control? No. Right? If it said that, that would be the right answer. So what it's saying is, picking the foot up and slowly behind it, what it's trying to do is if they do that, what do you think is going to happen to that side? What are they going to do with a paresis? Yep. They're going to be pushing to that opposite side. So you're going to have them stand up and try to keep what with their body? Neutral. Right? We want them to stay here. Which is harder to do, walking backwards or walking forwards? backwards, right? And that's going to challenge the synergy patterns the most because it involves more cortical processing, right? So that's going to trigger a synergy pattern more than walking forwards is going to trigger a synergy pattern. Does that make sense? Because this, what kind of control is this? Eccentric control, right? So that fires more neurons than concentric control and picking the foot up and putting it forward. So there's a couple reasons for that. Number one, I'm looking at it, gait quadricep control is really not going to help too much for gait, except for maybe standing up. Because once we're up, are our knees pretty good? Yeah, usually if she's up and walking already, she's probably got decent quad control, right? But what's happening is that we're talking synergy patterns at this point. So the problem we want is we want her to start triggering those synergy patterns so we can normalize them. And the best way you can do it is challenge on the brain. I know the book says all the others represent synergistic movements, supine, blah, 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 but I'm looking at it strictly from a gait standpoint. I wouldn't even worry about synergistic patterns in this one. I'm more worried about gait. If she wants to do gait, I want her stepping. Right? Does that make sense, though? Anything else you guys can counter synergy that you might want to talk about? Are we okay on synergies, other than being freaked out about them? But again, 3 to 4 questions, maybe. Don't freak out too much on that. I realized you guys are worried that those 3 or 4 questions could cost me it. But be more worried about getting the bigger groups of questions than the little groups of questions. Worry about the patho, worry about the neuro. Does that make sense? You got a question?
Something about, I forgot the question.
Okay.
Which ways to balance, whether you have when you're kneeling,
Okay.
either front or back. Some of the questions. I just remembered what you're talking about.
Do you remember if it's school builders?
Was it half kneeling? Is that what I was
Yeah.
talking about?
The half kneeling question, yes.
Okay.
They were,
Oh, I know.
I think also hemiparesis.
Yeah, it's an
Okay.
And it was
Right.
the affected leg, basically.
Which one?
Do you want to put it forward or do you want to put it back?
Yeah.
Would you
Oh,
put it, would
half
you
kneel
order?
forward or half
And which one did the question tell you to do?
Put it back.
Put it back.
Put it back.
Right. And that's going to make sense. Why? Let's just
similar to this, right?
think of this, and also let's think of tandem stance. When we're challenging a patient in tandem stance, what leg do we put back? The affected leg or the weak leg, right? That's our balance leg. This is our stability leg. This keeps us neutral. This is our balance. So same thing when I get into half kneeling, right? This is my weight bearing leg. This is kind of my stability leg. So I want the weight bearing down through the affected side, right? That's eventually going to lead me to where I'm weight bearing with walking. Right? But at least on the why would you start down on the knees? Because it's closer to the ground, right? They're not going to fall if they're down there, right? So we're usually going to start them on a mat, like a low mat table, like we have in the back with that. Does that make sense? So it's all about weight bearing status. And also, if they have an abnormal synergy again, if they put that leg back, that's going to trigger that abnormal synergy, and we can work on normalizing the abnormal synergy.
And that's what you want.
Yeah, we want to normalize the abnormal synergy. Initially, in the first 2 or 3 days of neuro rehab, we're going to use the abnormal synergies in order to help at least get them out of bed. And then once we get past those 2 to 3 days, we're eliminating the abnormal synergies. Does that make sense? And that's Brunstorm technique, pure and simple. We don't use Brunstorm a lot anymore again because we're using more functional motor recovery like Dr. Chickatelli taught you guys. And, I know he said it's a bad word, but I use constraint-induced therapy a lot with my stroke patients. But either of those we use once we get past those first couple days. But functional motor recovery, the one he's teaching, is kind of like the new cutting edge stuff. And I've seen it a lot now. It's like there's a therapist down in Tucson that I work with that's working with strokes that's all he does. He goes in the morning, he's like, what do you want to do today? Do you want to walk or do you want to? And I'm like, oh my gosh, it's Dr. Chickatelli. And I'm like, I'm going to tie up your arm now. Does that make sense though, Victor? Okay, cool.
Oh, I found it.
Oh, you found it?
Yeah.
You found what?
The question.
Oh. But does that make sense for the answer though? Are we okay on that?
Yeah.
Okay.
It's on 916.
916, which book?
Score builders.
Square Builders?
Question 15.
Let's see what they're...
Yeah.
Yeah, so if you look, it says half kneel with the involved leg posterior is the most difficult position.
Yeah.
which is exactly what I kind of just said, right?
Makes sense.
Yep. Yeah, I know something.
Yay. Yeah, it made more sense than any of these explanations.
And you understand the book's going to try to cover from a, what do you call it, a book perspective, and I'm just going to cover it from a functional perspective. All right, ataxia and apraxia.
Question.
Yeah.
Last on the synergy. So
Yep.
basically, like on the charts here where it says like upper limb, so if they have that abnormal synergy pattern, then it's just going to go into whatever.
Yep, so if they have a flexion synergy, they're going to look like all of that.
Okay.
If they have an extension synergy, they're going to look like. So what the book might, or the question might ask you if the patient presents with an extension synergy, you can expect the upper extremity to be in this position. That's typically what their synergy questions are going to be like. Does that make sense?
Yeah.
So you can, so if they have extension synergy and expect that, the scapula is going to be protracted. So what's that look like? Right, this, because this is retracted. The scapula's here. The shoulder's going to be adducted and internally rotated, so I look like this, right? And then the elbow's going to be extended, right? Forearm's going to be pronated, which kind of goes, if I go into internal rotation, don't I automatically go into pronation? Right? Wrist and fingers flexion. So if you look, both of them, they pretty much go into flexion, whether it's extension or flexion synergy. So they're never going to ask you a question about the wrist. Because they both go into that, right? So extension synergy, the main thing, again, just like PNF, when you're dealing with extension or flexion synergy, it's talking about the big joint. Does that make sense? So it's not talking about here, it's not talking about here. A lot of times when you're talking flexion extension synergy, it's talking about the big joints. Are the elbows, shoulders flexed? Are they extended? Are the hips flexed? Are they extended? Because the hip's going to end up in, if you look in flexion synergy, the hip ends up in flexion. And extension synergy ends up in extension. Right? So again, that's where PNF based off of, is a lot of that extension and flexion synergy stuff. Are we okay on synergies then? Ataxia, apraxia. You're like, maybe. Sure, get away from it. I don't care.
So I have a question.
Yeah.
One more.
Yep,
So
fine.
walking is a normal synergy.
Walking would have a
What-
normal synergy.
What other thing would be normal? What other?
What about rolling?
Okay, so what?
Right.
Like the baby reflexes. those
Baby
are-
reflex, right? But what about for us for rolling?
Okay.
What kind of stuff would be normal for us for rolling? When you try to roll over, what do you do with your arm that's on the bottom, usually? Do we want it here? Doesn't work very well, right? We automatically kind of stick the arm out or kind of put it up here when we roll. That's a normal synergy. We start rolling, our body kind of automatically does it. We don't even think about it. Because if I'm laying here and I try to roll to my side, and I keep this arm to my side, it doesn't work very well. Right? I just kind of automatically do that to help roll up. So that would be a normal synergy pattern. Right? Your head motions. Right? So when we rotate, the SCM's motion is a normal synergy, right? So kind of this motion, that motion, that's a normal synergy. And also, reciprocal inhibition is a normal synergy pattern. If I flex one muscle, the other should relax.
Okay.
That's a normal synergy pattern.
Thank you.
Yep. Are we okay with synergies now?
Yes.
All right. Ataxia, apraxia. Ugh. This one's fun, right?
No.
No?
No.
Why is it not fun? I like ataxia and apraxia.
Wait, 71.
So I think I have it.
71 to it.
And then it goes away? Right? Ataxia and apraxia are kind of your challenging ones, but remember, when we're dealing with those two, I find where is it? It's got the, I'm trying to find the one that page I'm. What? Yeah, I'm trying to find the one, there's a specific page I'm looking for here. Yeah, 283 might be. So the main thing we're dealing with, okay, first of all, let's break down ataxia versus apraxia. What's the difference?
One's taxing.
Right? Planning. Yeah, right? The P is for plan. So in this case, we have functional motor function problems with the plan. In this case, usually the plan's in place, but the implementation of the plan is the problem. Does that make sense? So that's the way I remember it, is when I see that P, I think of the plan, right? So that means that if I have apraxia and I have problems with planning, I can move my leg normally. My leg works. But when I'm trying to do gait, it's not doing what I want it to do. The plan is not in place, right? So functional motor, okay, right? Versus ataxia, I know I want to step my foot forward. I know I have to step my foot forward, but it's either nerve system that's screwed up, that's not sending the signal down to my muscles, or the muscles themselves are going, nope, I don't want to do it. And I don't get a normal plan out of it. Don't get the normal progression. And then the two, when you're dealing with apraxia, the two that you deal with, have you had questions on idea motor and ideational? A little bit, right? That's page 71 out of Therapy Ed. If you look at the very top, they have idea motor apraxia and ideational apraxia. And the main thing they're going to ask here is they're going to ask, trying to kind of explain what the difference is between them. So, idea motor apraxia. They can perform the task on command, or can't do the task on command. So if you ask them to walk, they can't walk. But if you leave them alone and they're not thinking about it, they can walk. Right? So that's implementation of the plan. Right? They try to do it, they can't do it, but if they're not thinking about it, for some reason they can do it. Because what would that be then? What? That would be idea motor, but that's just basically reflex. Right? Think about it. How many times do you brush your teeth in the morning? Hopefully every morning. How many times do you think about brushing your teeth? You don't, right? You just go in, you put the toothpaste on the toothbrush, you wet the toothbrush, or however you do it. If you do it first, I don't know. Put the toothbrush in the mouth. What?
You have to let it first.
Oh, I'll do it the other way. But then you put the toothbrush in your mouth, and you're sitting there, and half the time you're thinking about, oh God, do I have to study for ideomotor or ideational apraxia? You're not even thinking about brushing your teeth. Right? So a person that has ideomotor apraxia has that level of function, but if I tell them to brush their teeth, they can't do it. Does that make sense? Because they go, okay, I know what I got to do, and they try to do it, and it just the plan doesn't implement. But if they're just sitting there and they grab a hold of the toothbrush, they can brush their teeth without thinking about it. They've got the reflexive ability, just not the on-command ability. Then ideational is the real bad. So ideomotor is okay, ideational is the worst. Because ideational means they can't do it on command or reflexively. Right? So this patient, you ask them to brush their teeth, you put them in front of a toothbrush, a sink, and everything like that. Doesn't matter what you try to do, they can't do it. Right? When you're dealing with the apraxias and the ataxias, what type of diagnosis are we dealing with usually? What's that? CVA usually, right? Maybe CP, depending upon how bad the brain damage is with CP. Right? And also some muscular dystrophies as well. And that's mainly the ataxias versus the apraxias. Right? The kids know how to walk, but their muscles are saying, no, not going to do it. Does that make sense, though, between the two? So when you're looking at apraxia versus ataxia, you want to look at planning versus functional output.
Which is in finger to nose.
Okay? So let's use that, finger to nose. That's going to be ataxia unless they don't understand how to do the finger to nose. That could be an apraxia. Right? So you tell them how to do it, and the whole time they're doing it, they're doing this. That could be an apraxic movement, right? But if they know, okay, you see them doing this and this happens. That's probably an ataxic movement. They can't get the functional point where you want to go, right? Which is why usually when you have a little bit too much alcohol, you become ataxic. The motor plan's there. You know you want to get in your car and drive, and you know how to drive straight. But implementing that motor plan is not so great. And then you have Las Vegas Metro behind you, right? And then they tell you to get out of the car, and what's one of the tests they have you do? Walk in a straight line, right? So you know how to walk in a straight line. You know, okay, so I'm going to put my foot here, right? And then for me even, with my problems with my vestibular system, it's hard for me to do that, right? So I try to do it. I can get one foot. I can get that right foot really good. My left foot's where I start kind of being shaky. They're going to give me a breathalyzer test every time, right? The plan is there. I know how to do it, but I had that little bit of ataxia in implementing the plan. Does that make sense? Does that give you a visual at least or help you with it? So the main thing is when you're dealing with when it comes down to when you're looking at an apraxia, it's either ideomotor or ideational. Ideomotor, they can do it well volitionally, not trying to, can't do it on command. Ideational, they can't do it at all. That's the worst form. Does that make sense though? Are we okay on apraxia?
They can't do it on command because they can't.
Right, because you get in there and the plan's you're like plan not working, right? But they have the muscle memory. Remember, you ever hear that in the gym? You get muscle memory. They have the muscle memory to do the actual plan. They don't need the plan here. They can do it with just this, right? They can brush your teeth because their muscles know how to do it. Right? You ever do that? You go to the gym really tired, and you go over to do curls, and you're not even thinking about it. You're just like, you don't even have to think about it because your body's already there. You know what the plan is for the day.
Or like driving.
Or driving,
long
yep.
way And you just end up at home sometimes.
Yep, exactly.
Yeah.
So, like, wait, how did I get here? Right? Same idea. You just go into complete muscle memory, and your body just does it. Right? Or getting out and getting a shower. Sometimes you get out in the morning and get up and get a shower. You have no idea how you got a shower, but you somehow did it. And you're sitting at the coffee pot now. Oh, wait, how did I get here?
So apraxia?
That would be apraxia with planning. Yeah, that would be ideomotor, meaning you're not thinking about it, you're just doing it because of the muscle memory. Does that make sense though for apraxia and ataxia? You think so? I hope so. All right, upper motor neuron versus lower motor neuron. So I came up with, I took a course on the PTA that gave me a great kind of mnemonic to help remember this. Mnemonics are great, right? We like mnemonics. So, the mnemonic they gave me was storm baby. Right? Storm baby. S-T-O-R-M baby. Right? So what it does is when you're looking at upper motor neuron versus lower motor neuron injuries, you're looking at their strength, their tone, other, which classifies then in under clonus, right? I don't know why I didn't put a C there because it wouldn't make sense then. Reflexes, muscle mass, and Babinski reflex. So when you have a lower motor neuron injury, the main thing you have to know is everything is going to go which way? Yeah, everything's going down, right? So remember when we have it, so we're talking about, I did my beautiful drawing up here. You see how wonderful this is? Right? So here we have our anterior horn cell. When you have upper motor neuron injury, where's the injury at?
Brain or spinal?
Yeah, above. So it's somewhere here or up. Right? So central spinal cord related or up in the brain. Versus lower motor neuron injury is after the anterior horn cell. Right? Does that make sense? So typically in a lower motor neuron injury, everything's going down. Meaning your strength is going to go down, your tone's going to go down. You will get some clonus with it. What's clonus again? You pull back, right, and then you get this. And they may not be able to stop it. They may just keep doing it, right? What's that part of? Yeah, your DTRs, right? That's an overactive DTR. Your reflex overall are going to be down, but when you trigger the reflex, you can end up with clonus initially. So if you trigger the knee reflex, smack that patellar tendon, it's going to be diminished, but what you might see is still the leg sitting there going and unstoppable for the patient. You may have to stop it for them. The muscle mass is going to end up wasting immediately. Why is the muscle mass going to waste immediately in lower motor neuron? Yeah, it's not used, it's not getting any signal, right? It's going away. Bye-bye, see you later. Right, so you're going to have immediate wasting in lower motor neuron, where initially with upper motor neuron, it's going to remain pretty static until you stop using it, and then you'll end up with disuse atrophy. Does that make sense? And then Babinski. It's negative in lower motor neuron, positive in upper motor neuron. Right, so toe up versus toe down. So this is something cool. Like I may not help you, it helped me a lot remembering these. When I saw this, I'm like, why didn't they tell me this when I was in school? I don't know, somebody just came up with it. So storm baby is kind of a way to remember it. But just remember that if you have that, you're talking about either a spinal cord injury or a stroke. If you have a stroke, what type of motor neuron injury are they typically going to present as? Upper, right? So that means when you're dealing with a stroke, start thinking of the upper motor neuron symptoms. Does that make sense? Don't even worry about the lower. Can they have lower motor neuron symptoms? Well, maybe if they have a spinal cord injury on top of the stroke, right? But for the most part, they're going to present with upper motor neuron because it's in the brain. It's above the anterior horn cell.
What if injuries to the anterior horn cell?
That's when those are the fun ones. Those are the ones where they present as both,
Okay.
right? And in that case, there's not going to be a specific question about that, but if you see a patient like that, it's really messed up presentation. Because they will have, not only will they have a good strong DTR, but they'll have a DTR with clonus at full DTR. So you'll hit the bicep here, and they'll be going like this with clonus. And it's almost impossible to stop. If you try to stop it, it'll actually can cause a tear. You have to let it just calm down on its own. It's really bad. So ideally we don't want those. And the good part about it is, your good chunk of your spinal cord is protected in that area, all right? So you're not typically going to get it. It's either going to be above or below. But does that make sense for upper motor neuron versus lower motor neuron? Storm babies, I like that new mnemonic. It helped me now. Yep.
What did it say right after, right next to muscle mass?
Muscle mass, slightly less, meaning it's going to take longer to waste away in an upper motor neuron injury. And the reason it's going to take longer is because tone is up. So they're getting a little spastic, they're hypertonic, so the muscles are firing temporarily, right, until that signal completely wastes away, and then they'll start atrophying. Right, so the tone itself is up in upper motor neuron, so they're getting spastic, so the muscles are firing. Right? Does that make sense? So if the muscles are firing, you're not going to lose tone right away, or lose muscle mass right away. Either way, the strength's going to go down because they can't volitionally contract. Right? They can't. That's why when you see a patient with a real bad stroke, what's their arm look like? Right? But if they end up getting a spastic muscle, it's really hard to get that muscle out of spasm because it's stuck there. Right?
Lower motor neurons even get that F word?
Facilitations?
Yeah.
Fasciculations. Yeah, you can get them. That's part of clonus.
Okay.
What is fasciculations anyway?
Muscle twitching.
What's that? Yeah, it's microcontractions. Right? Are they present in upper motor neuron?
No.
They may be absent at the beginning, they may be present later on, but they're usually absent in the beginning. Right? Because DTRs are still intact. That's usually what triggers off your fasciculations. Does that make sense though? That chart help a little bit? And then like I said, I like both charts in the books. I think, if I remember correctly, where's the one for upper motor 72? I want to say it's score builders that I like the best. Or therapy ed that I like the best. Yeah, see, I really like therapy ed's upper motor neuron versus lower motor neuron because I think it breaks down the disorders that go along with it better. Because you get, if you look upper motor neuron stroke, traumatic brain injury, spinal cord injury, and you keep going up, it gives you a little bit of diagnosis with each of those. So let's use me as an example. When I had my spinal cord injury, did I have an upper motor neuron or lower motor neuron injury? Remember what I said, what happened to my arm 2 weeks after I had my spinal cord injury? It went what? It went numb and flaccid. So literally it was just kind of dangling. So I had a lower motor neuron injury. Yeah, right? So my anterior horn cell was there, signal was getting to it, but after it in that brachial plexus, which Kevin wants to talk about later, the signal wasn't getting out the brachial plexus to my arm because I was having a crushed area of the brachial plexus, right? So that's an idea. That's the kind of spinal cord injury I had. Does that make sense, though? Does that help with those? Does that help with those? Oh, you're not answering. Okay, good. Sam, you doing okay there? Okay.
Hi, Sam. Do you want a picture of that, Sam?
Sam, they want to know if you want a picture of that then. He said yeah. All right, so I think I'll let Dr. Chima come up and talk about Ionto, biofeedback, phono. I had a couple people that asked about that. And just the basics. Again, this is not something you're going to have a ton of questions on. The meds for Ionto and bio.
The polarity.
The polarity of the meds.
Oh,
Yeah.
So I'm going to write something up on the board that I have from a modality book that we didn't use in this class. Thank you.
Yep.
And I'm going to suggest you write it down. Because most of the questions about iontophoresis are regarding the amount of dosage, and it could talk about the time of dosage, and then the polarity of the dosage. And previously, I used to just tell the students, like Mr. McKeever says, I like therapy aids sometimes better on their charts and score builders others. So I think that's something, find out which one you can remember better, which one resonates with you, and use that one. So I like to use the therapy ed for the Ionto, which is on page 368. And then I'm going to put this up here for Ionto. And then, so you're going to need to know the current amplitude, which is measured in milliamp volts, okay? And so 1, 2, 3, or 4. And then the treatment time, can you all read this?
Yeah.
They can read my handwriting, they can read yours. Trust me.
Is, so if you have 1 milliamp, your treatment time is going to be 40 minutes. Because your dosage is going to be 40 milliamps per minute. This is the ultimate that you want to get to, is the dosage. The dosage is always going to remain the same. You got that right? So like 40 milliamps per minute. So if I go with a current amplitude of 2, and I go for 20 minutes, you see how you do it? So 1 times 40 is 40. 2 times 20, same dosage. Does that make sense? And then if I do 3, how many minutes in order to get our 40 milliamps? 13.3, right? 13.3 times 3 is 40. And so if I do 4, and this is the most frequently used one, is the 4 milliamps. You just go 10 minutes and you still get the same. Right? So when I taught you in modalities, I would always say, remember 4 milliamps, if that can stick in your head. This is the most recommended to use because it only takes you 10 minutes with your patient. When would I want to increase the time based on my patient's symptoms, reactions?
Too much for them to handle.
How would I know if it's too much for them to handle? What would I observe?
Redness.
Yeah, that's where you're going to get the redness, the skin irritation. So when you take the little Ionto pad off, you're going to see the red, possibly a burn. You might get burning. Or the patient can't tolerate the direct current. Okay, right? Because remember, Ionto is direct current. So a couple things that you're going to have to remember. Ionto uses direct current, and then the dosage is always going to be the 40 milliamp per minute. The most desired dosage is 4, using 4 milliamps for 10 minutes. But based on your patient's symptoms and tolerance, you may have to adjust it accordingly. Okay? So if they use those patches, the patches are still delivering the 40 milliamp per minute dosage, but what happens with the patch? They put it on, they have the little built-in battery that you pull that little tab out and it starts delivering the medication, and it may take them like 2 hours, 4 hours. What happens when all the medication has been delivered? It automatically shuts off. So just so you can kind of have some perspective. Now, if you look at page 368 in the therapy ed, this is the one that I like to use for iontophoresis, but if you like the score builders, it's the same thing. What you want to know is you're going to have to know some of these, okay? Because they may, in fact, ask you about the medications. So the most commonly used, which ones do you think on page 368 are going to be the most commonly used ones? Which ones? So the lidocaine is what? An analgesic. Why would I use an analgesic with iontophoresis? If it's hard for them to tolerate this 10-minute treatment, right? What we'll do is we'll go in with the lidocaine and put that on first. And the lidocaine is positive. So what direct current pole do I need to use on my current? Likes do what? Repel. So I'm going to need to use the positive pole to repel that lidocaine into the skin. Does that make sense? Anode, right?
Yeah, it's the anode. You're right.
Cathode's negative.
The anode is going to repel the anions.
Because there's a question in therapy when you're done. That was confusing.
Okay. Yeah, anodes are positive, cathodes are negative. So usually we do that for 5 minutes, the lidocaine, numb it up. Then we'll go in and commonly, what's the most common one used with lidocaine? Do you remember from modalities at all? It's a long time ago. It's actually dexamethasone.
You're right on.
Or hydrocortisone, an anti-inflammatory. So dexamethasone is what? Negative. So now I'm going to have to switch the electrode on my direct current and use the negative pole to drive the dexamethasone in. But if I'm using hydrocortisone, I'll use the same pole. I encourage you to somehow memorize those, okay? Those are going to be the most frequently used ones. The other one, which other one do you think you might see? I don't know what you've seen in their questions or not, but let's just see what you think. Of those listed, calcium deposit, dermal ulcers, edema reduction, fungal infections, hyperhidrosis, muscle spasm. Clinically, which one do you think you're going to use the most common? It could be, but what we see in the literature usually is where you use for ulcers.
Yep.
And that's the zinc, which is positive. So if you can't memorize this whole table, because I know you've got a lot on your plate, and I don't know how many questions you're going to get from Ionto.
Maybe one or two.
But what I'm recommending is you memorize lidocaine is positive, dexamethasone is negative, hydrocortisone is positive, and zinc is positive. You think that's fair?
Yep, that's fair. Absolutely.
And then I would write this down or take a picture of it, or I actually have a card I can pass around and you can take a picture of it on your phone if you want. But this is going to help you if they give you any type of indicator of time. Okay? You want me to pass this around and you can take a picture of it with your... This is from Cameron's modality book, which we used previous to your semester. And we both like Cameron.
Yep.
It's really a good book. And I just want to look on my notes on the back about biofeedback. So I'll pass that around if you take a picture and then circulate that back down to me. So what other questions did you have? Crystal, did you have a specific one or?
There's one, page 878 in therapy, question 134. And I haven't
In score builders, you mean?
Yes, sorry.
Oh yeah, I'm like, there's one.
Who's like, there's not 878 in therapy yet. It's okay.
I haven't reviewed this section, so I don't know.
That's fine.
And which question?
134.
I'll let Mr. McKeever read it.
So a PTA would like to minimize the likelihood of a burn when using iontophoresis. Which action will be the most consistent with the PTA's objective? Increase the size of the cathode relative to the anode, decrease the space between the electrodes, increase the current intensity, decrease the moisture of the electrodes.
Okay, so with this, the way I would answer this, and I haven't looked at this yet, is first of all, it's not asking about time.
Yep.
Because time would have been really the most critical factor, to be honest with you, but I didn't write this question. So next, let me take a look. Increasing the size of the cathode, so that's the negative relative to the positive.
Mm-hmm.
So what they're talking about that is the cathode being like the dispersive electrode.
Oh.
So, right, because
Yep.
it didn't say which one is positive or
Right, didn't say
negative.
what, didn't say the med.
Yeah, which, that would have been helpful, okay? I'm just like deducing it from my own background and experience.
That makes sense.
So dispersive, you're thinking dispersive electrode now. So that would have been a viable answer. Let's look at the other ones. Decrease the space between the electrodes. So if we decrease the space, what's that gonna do? So if we have a dispersive and we have the direct electrode, do you remember when we talked about electrode placement, and we didn't really utilize this with the newer models that we have, but do you want the dispersive electrode to be closer or farther away? Farther away, yeah. So it should at least be the diameter of the active electrode that far away. Does that make sense? So decreasing the space between them is gonna make it worse,
Yeah.
right? So let's look at the next one. Increase the current intensity. So do we wanna increase the intensity? No, not if they're already complaining of burns. And then decrease the moisture of the electrode. We know that increasing the moisture does what? If we add water or gel to our electrodes, do you remember when you were trying to get contractions? Did that decrease the pain of your patient or increase it if we added the gel? Right, so we don't want to decrease that. So the best answer is increasing the size of the negative, which is the dispersive, even though they didn't identify
Yeah.
what
And
what
if,
polarity.
and if also I can chime in on that, so positive is going to create an acidic or an alkaline reaction. Do you remember that from physics?
Which is physics?
Yeah, we did. You took physics. Positive is going to cause an alkaline reaction. Positive is basic. Negative is acidic. Which are you more likely to get a burn with?
Basic.
Basic. Right? Acidic is more likely to cause tissue damage. Whereas you're more likely to get a burn with alkaline. Right? So if you have a small, if you have a smaller pad, you're more likely to actually end up with a worse burn. Does that make sense? The bigger pad's going to help out, and it's going to disperse the chemical better. That's the other thing I would look at that one with.
Anode is alkaline. Okay.
So anode is that positive first of all. So which remember cats are negative. So the cathode is negative. Anode is positive. So positive causes alkaline, negative causes acidic. That would be my other way of looking at it. Her way is great. The other way I'd look at it is going, oh, I'm trying to prevent an alkaline reaction, so I want my negative pad to be bigger so it sucks the ions there faster. Right? And the other three answers, the way she broke down the other three, are exactly the way I would have broken them down too. It's, nope, I don't want to decrease the water. Nope, I don't want to increase the current. And I definitely don't want to decrease the space. So my only option is one.
And sometimes you just have to do that deductive reasoning, like Mr. McKeever has talked to you in other classes about. If you're not really sure, then figure out, for sure it's not that. For sure I know I'm not going to decrease or take away the moisture, and then try to deduce the other ones.
Yeah.
Okay, any other questions about iontophoresis? And then I'm just going to briefly talk about biofeedback. You good with Ionto? I recommend writing that down.
Yep.
And I would put a star by this one, because clinically, this is the one we're going to start with, unless we have any other indication that the patient's not going to tolerate it, or they are sensitive, they do have reactions to electrical conductivity. Okay, so with biofeedback, I think you have the pages written up here.
I didn't put the biofeedback one up there. No, I
It's
couldn't find it.
Score Builders, page 646. I didn't really find anything specific in therapy ed.
No, there's not. So I couldn't find
So
it either.
Score Builders, page 646, there's just a little couple paragraphs about why to use it. It shows like a portable unit like we had in our class. But really the biggest thing with biofeedback is the electrode placement and the sensitivity. So just a quick review, what do we use biofeedback for? What are the two most common things? They're on page 647, that first column at the bottom. We use it for muscle relaxation or muscle re-education, right? So in muscle relaxation, what are we monitoring? What do we want the muscle to do? Yeah, or decrease the muscle firing. So what you have to think of, biofeedback does not initiate a muscle contraction, right? It's not efficient. It monitors the muscles that are firing. So when you're using it for muscle relaxation, they're recommending you use a high sensitivity. So high sensitivity means what? If I have my biofeedback monitoring, high sensitivity, would it detect the slightest? Yes. So high sensitivity means it's going to pick up the slightest change in muscle activity. So in the case of muscle relaxation, we have a contracted muscle and we want to detect the slightest type of relaxation. So that's why with muscle relaxation, you're using a high sensitivity. Now, with muscle reeducation, we want the patient to perform a contraction. So there, you can have a lower sensitivity because you're going to expect you're going to get a lot of muscle firings, right? Which will set off the machine if it's too highly sensitive. The only reason I would go contrary to that, and you'll have to look at your information presented in your question, is if you have somebody post-surgically, right, and we're muscle re-educating, and we're trying to get them to elicit a contraction, and they can't, then at that point you may have to adjust the sensitivity to a high sensitivity to pick up even the smallest contractions. Like in our lab, we use the vastus medialis oblique muscle for that. So with electrode placement, just based on what you know, if I need to detect the slightest of sensitivity, do I want my electrodes close together or farther away? Yeah, because that's going to pick them up superficial. The farther away I move my electrodes, do you remember what that does to the current? It goes deeper, yeah. So just go back to your basics. You know, break it down. Electrode placement, the closer together, the more superficial, the farther apart, the deeper. So if I'm doing muscle re-education, I can move them farther apart to pick up that deeper muscle contraction. If I really just want to detect any slight movement, I'm going to put them closer together. Was that helpful at all? Mm-hmm. And I just want to say, I'm so glad you all are here to review. We understand it's very stressful preparing for this exam, and you do need to work in those rest days. We didn't incorporate that into your plan because if we weren't very good about communicating that when we had our individualized study plans, we want to communicate today that you have to take care of yourself. If you're feeling run down and sick, you've got to plan that in. Take your days off. Like I would even recommend before you take your first peak, you need to simulate that as your national exam. So I recommend the day before you take your peak, at least take that from noon on, the night before, just take it off, right? Because you don't want to go into this 4-hour exam exhausted, sick, worn down, okay? And then, any other questions about modalities, Jeff?
Oh, no modalities, but regarding the P, when did we get that email?
It was sent out like right after, I think.
Yeah, you should have gotten
Like
that.
that same
Like the
day.
day of.
Yeah, I didn't even do
Check
your spam.
Check your spam.
So send me an email if you didn't get your diploma, because I've already forwarded those to our registrar's office so they can start checking into that. Here's what I recommend if you didn't get your PEAT, is check your spam and call the FSBPT. Ross, call the FSBPT.
Yeah.
If there's did you got your first email from them to set up when you registered and everything?
For that, yeah.
So it should have been sent to that same email.
Yeah.
Because we didn't enter the emails. They were already listed as per your initial login setup. So So if there's any glitches in that, you need to call them on Monday morning.
Yeah.
Remember, it's East Coast time, so you could actually call at, what, 4 a.m.?
4 a.m. Yeah,
Yeah,
if you wanted to.
and then let me know, okay, because I can always follow up with them also.
Yeah.
Who else didn't get their Pete? Yeah, so
The same
same
thing.
thing.
And anyone watching this video do the same thing.
And then take a look at Victor's and Crystal's email that they got, just so you know what it should look like, okay?
You may even just want to search for that if you have Gmail. Search what it looks
For
like.
the 14th.
Yeah, that actually went out the day after you
Yep.
graduated.
Same
Yeah.
thing. So we just sign into the customer dashboard and then it'll.
Yeah, I think you just sign into your dashboard on the FCPT and it shows where you can go to your Pete. So you, Ross, you may actually be able to even just sign into your dashboard on the FSVPT and it should probably show there for you.
And then, but they have that.
The code they have to enter, yeah.
Yeah, code.
Hi Sam, you still doing okay? Oh, okay. Did she get a phone call? She hung up on you? Alright, lung volume chart. There's not much I can help you with on this one other than looking at it, guys. I wish I had a magic button to fix for this one, but this is just purely...
Make it more complicated than it has to be.
I think they do too. And I would tend to agree with you. The main thing I'm going to say is, so in Score Builders on page 361, what I would definitely look at is make sure you know what each of the abbreviations means. That's the main thing. And if you look at them, if you look at the abbreviations, you should be able to figure out expiratory reserve volume. What's that mean? Think about it just logically. It's the stuff that you have left over after you breathe out, right? Total lung capacity. How much you got in there, right? So that's the thing. So know what if you don't know those abbreviations, because the questions, I don't think you run into them. Most of the questions are talking about TRV, includes which of the following. If you don't know what, tidal reserve volume is, you're in trouble, right? So you have to make sure you know what they are. And then, honestly, it's just that chart. I wish I had some magical formula for this. There isn't. I hated this one. This is the one thing I hated most when I was studying for my boards was this stupid lung chart. Because I don't know why, I could not get this to save my life. And what I had to do is I had to convert this to algebra for me and create formulas and memorize the formulas. That was the only way I could do it because I'm really good at math. So if I could change this from just this abstract concept to math, I could get it. So I would create that, total lung volume or total lung capacity equals IRV plus TV plus FRV. And then I would write that. So I would write, TLC equals IRV plus, and that's the way I memorized it. That's the only way I could get it. It just did not stick with me. Now I understand what each of those means from treating a patient, but I have no clue. Coming out of school, I'm like, I don't know what this is. So I had to create a formula for it, right? And then percentages-wise, you're not going to get a lot of. It's not like they're going to get a lot of questions on your total lung volume is what percentage of your. Well, hopefully total lung volume is 100%, but right. But you're not going to get a lot of questions that ask you your inspiratory reserve volume is what percentage of your lungs capacity, right? When you're getting questions about this, what type of patients do you think you're having these questions on? COPD. Yup. And if we're dealing with COPD, which of the ones are we worried about? Anything that starts with an E. Expiratory reserve volume, expiratory, capacity, anything like that. All of that is what we're worried about with the thing. Which is the most important, or which is the one that causes them the most problems with COPD? ERV. Right? How much is left in the lungs, right? After they've gone because remember, they're having problems getting air out. That's why we go to what ratio for breathing?
1 to 3.
1 to 3, right? 2 to 4, somewhere in that range. At least getting more and more out. Good, which is we're going to teach them what type of breathing. Pursed lip, yeah. See how that all ties together? Yay! We learned something in school.
So as for numbers for this, it's basically just the percentages?
Just the
'Cause I know-
percentages. You don't have to know the volumes.
Okay.
Yeah, if you're going into respiratory therapy, you have to know the volumes. But for us, it's just percentages. You know, and again, most of the questions you're going to get are going to be on expiratory volumes because it's going to be dealing with the COPD patient. So that's the big thing I can teach you on that is learn the definitions, learn what the dead space is, learn what the expiratory reserve volume is, learn what each of those means. So study that chart that has the definitions, and then come up with a way that helps you remember what each of them are. I don't have a magic formula for this one. This is one that it's just literally sitting down and studying. Right? I know you hate me for that, but that's the only thing I can tell you on that one. That's it for that one. I'm done with that one because there's not much I can do on that. Imaging and testing. What kind of questions did you guys get on imaging and testing? I think Camille sent me the question.
It's like, I'm always confused on which, because they always ask like which imaging or test laboratory would you use?
Okay, so let's think about this logically. Imaging and testing. What are we going to use to detect fractures? X-rays. So X-rays look at what type of structures? Hard structures. Right? X-rays are for solid structures. Because what does soft structure show up as in X-rays? Dead space. So they show up at what color? Black. Yeah, they show up as black. So if you take an X-ray of the spine, you'll get each of the individual bones, but in between them, the discs are going to be white, or going to be black, right? You're not going to see the discs individually. So you can't tell if the disc is shifted either way because you just have a black space. What do you need to see the soft tissue then? MRIs, magnetic resonance imaging, right? Can you also see fractures on MRIs? Yeah. Yeah, MRIs are actually, believe it or not, MRIs should be the gold standard now because MRIs can show both. Why do we not do MRIs as often? Expensive, and also what's the other problem with them? The equipment, right? But what's the problem with patients? Claustrophobic. Yeah, hard to get them into the MRI, especially if you got patients 500 pounds. Finding a bariatric MRI is hard. And they have to go to one of the open MRIs, and that's even more expensive, right? Where are our open MRIs here in town? Does anyone know? So we have one down in Southern Hills. Sunrise has one, and then one of the Steinbergs, one of the Steinbergs over in Summerlin has one. Right, so that's only 3 in the valley. Think about that for a second, right? We're a pretty big valley. We only have 3 of them. So that means if you're at, UMC, and if you need to go in an open MRI, they've got to put you in an ambulance, take you to one of the other locations, right? So it's not good. So what do we use CTs for? Where do you normally hear a CT? What type of CT? 2 types. Chest CT or brain CT, right? What do we usually use in conjunction with CTs? What's that? Yeah, so nuclear testing. Yeah, right? So we usually inject them with some form of a dye. It's usually a radioactive dye. So they'll inject you with a radioactive dye. So when so remember, CT is like having an X-ray at what level? Do you remember that? 1,000. One chest CT is like having 1,000 regular X-rays. Yeah, Isabel's face says it all, right? So think about that. For an X-ray, you have a 1 in 1,000 chance of developing cancer from it. From a chest CT, you have about a 1 in 10. So every time you get a chest CT, you're really upping your chance, right? But that's why they don't like to do chest CTs unless they absolutely have to, or if they, in my case, when they take me in, they screw it up 3 times and I have to get 3 of them. So I've got like a 1 in 3 chance now. Thanks, thanks Desert Springs. Anyway, so chest CTs and brain CTs. What are we looking for usually in those? We're looking for angiographies usually. So we're looking for the blood vessels. CTs are usually used to either do nerves or blood vessels. So you can inject in either. Right? So those are more your structural type levels, right? But again, CTs are really, really, really high radioactive, so they don't like to give them unless they absolutely have to. So then we also have, PETs, right? PETs are not something that you have at home, right? PETs, what's PET stand for? Positron, yeah. Emission tomography, right? So it's literally shooting positive ions into the body and getting it to react with stuff that's positive in the body. Right? So that reacts well with like blood vessels, fluid, stuff like that. It's looking for dead spaces. Again, the brain's a great place to do a PET scan because what's the brain full of? Fluid and dead space. Right? You have, what are those things that hold all the fluid in the brain called? The ventricles. Yeah. Right? Does that make sense though for imaging now? Does that kind of break down what you need to get?
Which one is the invasive and non-invasive? So CT scan would be invasive.
CT is going to be invasive.
And then which is the least invasive?
The least invasive is going to be MRI. Because MRI involves no radiation. What is it? What are you using MRIs? It says it right in it. Magnets. Yeah. Right? You don't actually get any type of radiation at all from MRI. It's really, really low level. Right? You're actually more likely to die from cancer from going outside than you are from an MRI. So an MRI is kind of the gold standard if you can, but they're just expensive. So least invasive MRI, most invasive CTs and PETs. So for the most part, which type are we going to order as PT, or what as us, but what types are PTs going to order primarily? X-rays. Yeah. So most of, maybe an MRI if they can, right? Especially if we're talking soft tissue damage. But for most part, the most they're going to want to see is X-rays. Spinal cord, now we want to see an MRI. Right? And the nice thing about the MRIs and also even down to the CTs is we can do slice levels. Right? So an X-ray, if I take an X-ray of my leg, I just get an image of my leg. Right? If I do an MRI of my leg, I can literally go inch by inch down the bone and look where the problem is. Right? And that's actually the really cool part. Same thing with the spine, right? If I take an X-ray of the spine, I just get, here's the spine. Right? With the MRI, I can go level by level and look to see where the bulge actually is. Does that make sense though for the imaging then, Camille?
Yes.
Okay, so then the other is testing. So testing involves blood work and also lung testing, right? So what type of patients are we going to send for respiratory testing, primarily again? COPD or cardio. Yeah, cardio patients as well, right? So any type of heart attacks, strokes, anything like that that we're dealing with. So those type of patients we're going to send for just to see how functional their lungs are. What do they need to be doing in their room if they're in the hospital? Inspirometer, yes. Right? So you're working on that because it's usually over on the the heater under the pile of clothes, and it's still in the bag. Inspirometer is that breather thing that they have to do, right? Blood work. What kind of blood work do we usually look at? So when we're looking at the blood work. Platelets, INR, white blood cells, and then our 2 H&Hs, hematocrit and hemoglobins.
We need to know those values.
It's ideally platelets you want to know, because that's one I've seen a lot of questions on, right? So what's your platelet values?
150.
Yeah, so 150 to 450, 100 to 450, depends upon the book you're reading, right? Anything below that, are they therapeutically safe for therapy?
Yes.
What type? If they're below 150, are they safe for getting up and getting out of bed? Some are, right? Yeah, so down to 50,000, we can usually get them up. We don't want them moving a lot.
20,000.
Yeah, 20,000, no resistive therapy, right? So those are the kind of things you want to know. But ideally is, if you get down to those, start getting down into the single digits, what's going to happen to therapy? No therapy. What about really high values? What are we worried about with really high values of platelets? Clots. Yeah, we're worried about clots. So we want to know that they're clear, that they don't have any DVTs or anything like that. So if they're clear, usually if they have a high value, they're okay. But if they're not, if they haven't been cleared for clots yet, I don't want to get them out of bed, because what can happen? Lung dead. Same thing happened to the lady that just happened on my airplane that I just rode on. So just throw a pulmonary embolus on the plane. So you want to make sure that they're cleared for clots. H&H counts. What do we want? What does that tell us? Oxygen transport. Yeah. Right? So that's the main thing H&H show.
We don't need to know those specific values because they're a little different in each book.
Yeah, I wouldn't worry so much. They're a little different in each book. The main thing is that chart that you gave me is a really good reference value. right? I posted that. If you don't have it, I can repost it for you guys again. Would you say repost it?
Yeah.
Okay, I'll repost it. Yeah, that's actually a really good. That was actually a really good chart, and I use that now as my chart. So,
Can you look at then regarding question 854 and score builders?
854 and score builders. Page 854, I assume.
854.
Page 854, score builders. What question number? 85. 35-year-old is admitted to the hospital following a recent illness. Laboratory tests reveal a remarkably high platelet count. This finding is typical with, okay. So, first of all, I'm looking at platelet counts. Is there any there that I can rule out? Emphysema. Why? Lungs. Doesn't really count for platelets. I can rule that one out. What might be affected with emphysema, though? Which values and lab values? H and H. Right? Because emphysema is dealing with getting air in and out. So your H and H counts might be off. Right? But for platelet count, nope, don't care. Metabolic acidosis. Is platelets going to show that? What are we going to need to know for that? What value? 2 letters. pH. Yeah, the pH value we're going to need to know for that. So I can rule both of those out. Right? I need to either know blood pH or respiratory pH. Either of those will help tell me if I've got renal failure, which is actually going along with metabolic acidosis. I didn't see the next question. So this is one where you have two answers that, guess what, are the same. Metabolic acidosis, metabolic alkalosis are both potentials for kidney failure. Right? So either of those two there are the same. So the only thing I have left then is malignancy. That's literally the only thing I have left. And think about it. So malignancy means what's happening? Rapid cell growth. Right? Could a high platelet count be a malignant cancer? Could you have malignancy of the platelets? Yeah. Right? They could have cancer of the blood. What type of cancer of the blood is common that would cause platelet counts to go up? Leukemia. Yeah. Right? So that would be the way I break that question down. Is I'd go emphysema is definitely 100% out. Because that doesn't tell me anything. And then your next two are the same answer. Right? Because metabolic and acidosis and alkalosis are going to come from renal failure or respiratory failure. They're out. So the only one left is malignancy. How many of you thought that way? Oh, I'm just checking. I just went, that one. Does that make sense, though, for that one? So the main thing there, what I would look at is high platelet count, out of control growth, malignancy. I wouldn't even worry about the blood test itself. Because what you're worried about is, well, malignancy doesn't always have high platelet counts. I can see your brain working. And it's right. Not always does malignancy have high platelet counts. Because if I have bone cancer, I'm probably going to have what kind of platelet counts?
I was thinking white blood cells.
Yeah.
Malignancy.
But what else? If I have bone cancer, what's going to happen to my platelet counts probably? Decrease. Because what's bone help do? Make platelets. Right? The marrow helps recreate new blood cells. So it might actually drop. So yeah, I can see where you're going, I don't know. But the thing is, I just rule out the other three answers and be left with malignancy. Anything else on lab values or imaging that I can help you with? And then for us, it's just special tests is the other thing for testing. Knowing your Ober test, all those fun ones. Ankle ligaments. Ankles and ligaments. What kind of questions do we have on that we hit? That we had problems with?
I have a question, but I don't remember it. But I just want to go through emotions that they resist.
Okay. I want to say I like the one in. No, it wasn't therapy ed. It had to have been this one over here. Score builder 65. Oh, I'm on it. So if you look, 65 has all of your ligaments written out for you. That's why I like this one. The therapy ed talks about the different types of disorders for the ankle, like tarsal tunnel, plantar, pes planus, pes cavus, all that. but the actual the score builder goes through and goes anterior talofibular ligament. It resists this. It helps with this. I think you're going low on battery, Isabel. Just to let you know.
I have a charger.
I have a long cord in my bag if you want a long cord.
You can switch to this one. We can just keep switching phones.
Alright. Do you wanna call, do you wanna FaceTime Michelle?
Yeah.
My phone's gonna die. Alright.
I'll hold off on talking till he's back.
Okay, one second, man.
I'm at 87, so last.
Do we have time to go over after this spinal cord outcome? I'm so confused.
All right, I'll try. Let's see what we can do. SCI. Hey,
That was quick.
what are we up to? We're up to an hour and 30. We're doing okay.
Yeah.
There you are. Welcome back, Sam. Hey. Hey. So let's first of all, ankles. What's the most common ankle injury? Inversion sprain. Right? Why is not eversion sprain? Because of which ligament? Yeah, everything's stronger. Not only that, but when you think about it, think about the process of all the muscles going in as well. Right? It holds the foot. You know, it's easier to pull the foot this way than it is to pull the foot this way, right? I mean, like me, I've got almost no eversion at all. So it's going to be really hard for me to get an eversion sprain if I have no eversion. But inversion, I can stand on the outsides of my feet, right? So it's more likely to get that inversion sprain, right? And when you're dealing with ankles and stuff like that, the other question they often ask is, what is the position of comfort? Right? So when you have a sprain of the ankle, the position of comfort is always going to be the opposite direction of the sprain. Does that make sense? So if I do an inversion sprain here, my position of comfort is going to be which way? Everted and dorsiflex, because this is the way it's going to sprain. Plantar flex and inverted, right? So no matter where your sprain is, whether it's a sprain up here at the elbow, whether it's a sprain in the shoulder, whether it's a sprain in the ankle, whatever direction the sprain occurs, the opposite is the position of comfort, right? Do we want them to stay in position of comfort, though? No, but at least for the couple of days when they've got the swelling, we do want them. So that's the way we're going to wrap them. So if we wrap an ankle for an inversion sprain, we kind of want to evert them a little bit and wrap it. That's going to help also with the soreness. Which is your strongest ligament in the ankle? Deltoid's your big one, right? So I'm not sure what to cover here because there's so many.
So just the ones that say the ligament. Like I just want, because there's so many things. I couldn't picture the ligament and like.
Did you have a question on specific on it, or?
On all the ligaments. Like if you, I feel like if
Well,
once you say it,
yeah.
it'll sink
Well,
in.
so what you have to do when you're talking the ligaments of the foot, what you have to do is envision where those ligaments are. Yeah.
So,
I was having trouble with the ankle like on my second rotation. I just googled a picture of the ankle and the
Yeah.
ligaments, just the ligaments, and I like stared at that for a little bit, and it helped me like kind of figure it out. So maybe like while I was seeing.
Well, yeah, and your Therex book has a really good picture. The green Therex book you guys have has a really good picture of all the ligaments on the ankle itself, the muscles from remove, because it talks about the sprains. But the other thing is when I deal with questions dealing with the ligaments, most of the ligaments, with the exception of the deltoid ligament, tell you where they start and where they end, right? So calcaneofibular starts on the calcaneus and goes to the fibula, right? So what's it going to resist? Think about that. So it starts, I'm sorry if you can't see it, starts back here and goes here.
so it goes cross.
Yep, it's going to cross.
It's just I guess I can't
Right.
picture the ligament like how this.
Well, and that's why I'm trying to get you to look at the name.
Because when I was thinking it in my head, calcaneus go around, so
Right.
I'm thinking here and here.
Nope,
Okay.
it's going to cross. It's going to help hold it in place. So it's going to resist inversion, right? Because it's going to cross it. It's going to help resist you coming this way. And it's going to provide that spring back when you go into inversion to bring it back into neutral, right? Or like the anterior, so now we're talking on the front, talofibular ligament. So where's that going across? It's in the front of the foot going yeah, kind of crossing across there, right? This is going to keep the talus from moving, right? So it's here. It's going to keep. It's just like which muscle or which tendon or ligament in the knee. The ACL. It's an anterior ligament. It prevents anterior translation, right? So when you see that one, think ACL, right? Because ACL prevents the tibia from translocating on the femur. The ATF prevents the talus from translocating on the tibia. That makes sense? And then deltoid is that one fun one that's what? How's that look? It's a trapezoid, right? It connects everything together, right? And the main thing with that one is it helps keep everything stable, right? That's the deltoid ligament's primary job. It provides medial stability, right? So if it's on the medial side, that means it resists which direction? Eversion. Yeah, right? And then you have the posterior talofibular ligament. So again, connecting the talus to the fibula. That one's going to be like what? The PCL. Yeah, that's like the PCL. So it's going to prevent the talus from going backwards. Right? Because remember, that talus is just sitting on that mortise. Right? So it kind of moves. And you want to make sure that you don't get too much. If you shift it, we might have to do what to fix it? What type of treatment? Joint mode. Yeah, we might have to do joint mode to get it back in place, right? But those are the ones. So if I was studying, make sure you know your deltoid. That's the big one that they're going to ask you a lot of questions on, right? And the rest of them, when you get a question on those, is I would look at them and just think of where they go. So you have your ATF, which is like your ACL, and you have your PTF, which is like your PCL. Does that help you a little bit?
Yes.
Does that make sense though for the ankle then, guys? That's the main ones you have to worry about. The rest is just muscles.
I found a question on it.
Oh,
Okay.
It was a question in the base camp.
Okay, that's fine. What question did you find on it?
936.
936. Let's look. At least we can look at one. 936. Which question is it?
93.
Oh, I'm a 938. That's why I can't find it. 936, 93. 21-year-old female examined post in physical therapy after sustaining grade 1 ankle sprain. So grade 1, first of all. What kind of ankle sprain are we dealing with? Minor. Is it going to hurt a lot? Yes. Yeah, grade 1s hurt a lot. Right? Remember, grade 2 is a little bit less. Grade 2 is where do we have most of the pain? With movement. Right? At rest, usually okay. Grade 2 is movement. We start with what? Grade 3 is when do they have the pain? When it happens, and then what happens most of the time? Gone. Because what happened to the ligament? Teared. Right? It teared. Or it tore. It teared it. So grade 1, so she's probably got a lot of pain. 2 days ago, right? She was down at U of A in the marching band competition. Patient's description of the mechanism of injury is consistent with inversion and plantar flexion. Is that the most common? Yes, so she got the most common sprain. So she's walking along, tooting her horn literally, and rolled her ankle. Right? Which of the following ligaments would most likely be affected? So let's look at them. What one can we get rid of? Right off the bat. Deltoid's gone. Deltoid's gone because deltoid's going to resist which direction again? Eversion, right? ATF, are we worried about that with an inversion sprain? ATF is concerned with what? Which bone again? The talus and the tibia, right? That would be involved with the foot going this way. The foot going this way? Foot's going this way. Right, so ATF is out. What? I'm sorry. This is where we get the fun one. Yeah, get the tibia. I was talking about the anterior tail. Yeah. So anterior tibiofibular ligament actually makes sense. That's the cross one. Right, that's one of the cross mechanisms. That's one. So you have your. If you go back to those ligaments back here on what page was it again? 60 something, right?
65.
Yeah, 65. So it's also going to be another cross one. It's going to help present that. So you have your crural. What's it called? calcaneal or crural talar fibular ligament, the one cross, and then you have that one that goes like this. Again, what are we dealing with here? Which muscles does this look like? Or which ligaments does this look like? The cruciates, right? All your cruciates in your knee, right? So those are going to prevent this way and this way a little bit, right? So out of those all, the tibiofibular is out. Are we concerned with the tibia moving on the fibula, the fibula moving on the tibia? With the sprain at the ankle. So number 3, tibiofibular. Are we concerned about that? No. What do we get concerned about that? What type of condition? What's that? Syndesmosis sprain, or what other condition the patients get commonly that are walking or running a lot? Shin splints, right? Then we might be worried about that ligament. I'm just trying to rule out the ones here first of all. So deltoids out, tibiofibular, not a concern because we didn't get any type of syndesmosis sprain, right? Or what's the term that they call in football a lot? High ankle sprain, right? I don't know why we call it that. It has nothing to do with the ankle. It's up here, right? It's syndesmosis sprain. Calcaneofibular. Is that a concern? Possibly, right? It's possibly, right? But calcaneofibular is going to resist which motion? Primarily. What? Inversion in, that's right. Say it louder. You're right. Inversion in neutral. Right? Whereas this case, what are we dealing with? Inversion in plantar flexed. Right? So Ross is digging back to his ATC days. So he's got an advantage on this one on you guys. Right? But yeah, so typically, whenever you see calcaneo, when you're dealing with something, you're going to be dealing with the foot in neutral. Right? Because think about it. What are you guys trying to find when you're measuring the ankle? What's the place you're trying to find? Subtalar neutral, which involves putting the talus neutrally on the calcaneus. Right? Getting everything nice and lined up. And that's going to involve that calcaneofibular ligament. So the only thing left at that point then is talofibular, which is one of the cruciates. Right? So again, think of those ATFs and your PTFs as the cruciate ligaments of the knee. Does that make sense? That's the way I remembered it. And this one, what I do is I just rule out. I know deltoid's out. I know tibiofibular's out. Calcaneofibular could be, but it's neutral. And that's just one that you have to kind of, I guess neutral and dorsiflexion, isn't it, technically? Yeah, but typically we're not in dorsiflexion. We don't function. It's not like we walk like this. Right? But let's say I planted down here, I put down, and I rolled here. Could that have been calcaneo then? Yeah. Right? Well, what's happening is she's planting down and rolling like that. And that actually hurts. So that's just looking at it and going through and breaking it down. And again, that would be one that when I'm looking, if I'm looking at when I've got a plantar flex foot, I'm looking for a cruciate ligament. And what does cruciate mean? Cross-like, yep. All right. Are we okay on ankles? I hate ankles. I hate ankles, I hate hands. Those are the two that I hate. What'd you say? I hate feet and I hate hands. Because both of them are just so freaking complicated. And be glad that you guys don't have too many hands. I'm helping a therapist get ready for their hand exam, their CHT. They're paying me to tutor them on hand stuff, and oh my god. Right, Sam? Hand stuff? It sucks.
I have a last question.
Yep.
If you can.
I put a circle.
Okay. I think I read that the sinus tarsi you can palpate it. Like,
Yeah.
Where exactly? Show me.
Yeah. Ross, I have to look at that one. That one's one that I've.
Sinus tarsi goes through your.
Yeah.
And then basically, if you go into plantar
Oh, like
flexion-
that deep dip that I.
Yeah, it's a dip.
Okay.
Yeah.
So if you go into plantar flexion and invert, you should feel like tails pop up.
Yeah, the tail should pop up on it.
Oh yeah. Okay. Thank
Yeah.
you.
Dr. Kelly did that with you guys. Remember way back in
I do not
outpatient?
remember.
And the only reason I know that is because he just did it with the other group the other day. So we have cohort 10 guys.
Are they weirdos?
It's very strange to have cohort 10. It just seems really weird.
That's what you're-
I don't know why.
Are they fun like us?
They're all scared right now. So They're the little infants.
We were scared.
They're all terrified. This is the second week, guys. They're terrified right now. Dr. Shatelli just went out through all the framing of the skull, and they're all now. Like, I'll go back to that any day. Yeah, right, until you go back to it. Are we okay to mark off ankle?
Yes.
Okay. Brachial plexus. What kind of question on brachial plexus, Kevin?
Everything.
The whole thing.
The whole brachial plexus. Page 227, therapy, not therapy ed, score builders.
You need to know the specific branches, like the anterior branch goes here, that's how score builders breaks down.
Yeah, score, that's why I was breaking, that's why I picked that chart. Right? What do you need to know about, so, do you remember back when I talked about Erb's palsy? Way back in semester 3. What is Erb's palsy? It's a disorder of what? Brachial plexus, usually when? At birth, because what happens? Not what happens to the doctor usually. What do they usually do? They grab a hold of the arm and pull the baby out by the arm, right? Because they can't get a hold of anything else, right? So what you need to know about brachial plexus, you don't have to necessarily draw it out, like Dr. Kelly. It's good to know that, especially if you're going to work on the upper extremity, right? Because that helps you understand which muscles, right? Which goes where, which goes where. Like right now, I can tell you I'm having really, really bad symptoms of my lower cord. Because I'm actually, I'm not doing that. Right?
Maybe used to like play the flute.
What? Yeah, that's what it is. Well, no, I've actually, part of my plate is slipped. So it's compressing back down on my brachial plexus again. So I'm having lower cord injuries. Right? So I know that's going to cause problems. I have to go in, they're going to have to go in and fix my plate. I don't want that.
So when you say lower cord, you mean medial, like the medial cord? Or,
So posterior, when you go lower, it's posterior cord.
okay.
Right? So you're going down to that inferior portion, C8, T1, C7, that region, right? So superior, middle, inferior cord. And you have posterior. Posterior is a lot of what I'm getting symptoms on. Because I've got real bad pain. I've got Cloward sign in my shoulder, which is when you get pain specifically on specific parts of the scapula. You didn't have to know that because that's another hand therapy thing. I just learned that one there, Sam. The main thing you have to know about brachial plexus is you have to think about, depending upon where the injury is, what muscles are going to be affected. Right? So they may present that you have a brachial plexus injury at C5. All you have to know then is what? Your dermatomes and myotomes. Yeah. Right? So don't freak totally out about brachial plexus. If you know your dermatomes and myotomes, you can translate a brachial plexus injury. That's what you really have to know. You're not going to have to specifically know that the posterior upper thoracic suprascapular innervates subscapularis. Right? What you have to know is, it's going to say they have an injury at brachial plexus at C6. What does the presentation look like? It may ask you what the sensation looks like or what the muscle looks like. Does that make sense? And that's actually going to tie into spinal cord injuries too, because that's usually my answer for spinal cord injuries is know your dermatomes, myotomes. That's beside the point. But does that make sense then, Kevin? And then the other book has one on page, I marked it off here, I'll find it. It's cardio. So 281 in therapy ed, that has some conditions when you have brachial plexus injuries, which might be good for you to look at. So it talks about avulsion, how we treat it. That's the most thing you're going to have to know is how do we treat injuries of the brachial plexus? Well, initially it's just going to be like anything else. What do you think we're going to do at initial injury? We're going to rice it. We're going to rest it, ice, compression, elevation. We're going to take the arm, we're going to put it up here, we're going to let the plexus kind of heal. And then we've got to repair the plexus injuries, right? So what if they have plexus injuries, what type of stuff we're going to be doing with them in physical therapy? Are we going to do neural tensioning? What'd you say? Ow. Right? Neural tensioning is where we do the flossing. Right? We're not going to want to do that. What about E-stim? Would E-stim help with the pain? Yeah. Yeah, to affect those A deltas and those beta fibers and everything, like I get the pain firing down so that we can actually get motion. Right? And that's the ultimate thing. Now, if it's sensory, are we so concerned? If our brachial plexus injury is more sensory, so coming out of that dorsal root ganglion and back there, are we more concerned about that, or are we more concerned about if it's motor? Motor, we're more concerned about, yeah, right? I don't care that I don't have sensation in my arm, right? Because I can live without sensation. I can't live without motion. That's the main thing you're looking at is, so if it's sensation, if it's a sensation damage to the brachial plexus, what are we going to try to do? What type of treatment are we going to do? So if it's burning, tingling, hypersensitivity, we're going to try to desensitize. We're going to try to calm it down, right? If it's motor, we're going to then do muscular re-education, neuro-re-ed, right? So if I'm having problems where I can't weight bear down through the elbow, guess what I'm going to be doing? Weight bearing down through the elbow, right? If I have a problem with the elbow keeps buckling, I can put a brace on it and work on just kind of getting that weight bearing down through the elbow until I can take the brace off and I've got strength in the arm again. Does that make sense though for brachial plexus? So the main thing I'm going to tell you about brachial plexus, study your dermatomes and myotomes. That's going to get you through 90% of the questions. That's actually going to get you through 90% of your spinal cord questions too. So what about spinal cords then?
Well, okay.
Because you said recovery.
So I have a specific question.
You have a specific question. I figured that because that's usually what happens.
But I'm having trouble with the different cord syndromes. I guess it's just memorization.
Yeah, it is. That one is. I wish it was more.
Yeah, and then the outcomes, because the outcomes I feel like sometimes contradict each other.
Like, give me a question. That way we can kind of look at it.
Okay, so page 827, number 31.
827.31. 827.31. So let's look at 31. PTA reporting at discharge team meeting indicates patients rehabilitating for spinal cord injury should be able to perform household ambulation. Oh, this is one we kind of talked about a little bit, right?
No, this is a different one.
Oh, this is a different one? Using KFOs and crutches upon discharge. The patient's quadricep strength is currently 2+ out of 5. So in this one, it is strictly, it's pretty much a myotome question.
Yeah, but I thought you have to have 3+ to have, I thought 3+ was the cutoff for where you have to be muscle-wise in order to...
To gait? Or what?
No, what am I trying to say? Like for the level.
Okay.
Like to be considered an L3 or...
Well, this is not even asking what level they are. What this is asking is where the damage is.
Oh, maybe I'm thinking about it wrong.
Yeah, you are. You're thinking about where the neurological level is.
Yes, that's what I was thinking.
Right? And this is not asking where the neurological level is. This is where the injury level is. Remember, I talked about the neurological level and the injury level are different.
Okay.
So this is saying where is likely this damage to have occurred in their spine. Not asking where do they have full function at, which is neurological level, right? Because neurological level means what? Do you remember what it was from that lecture I talked about? Neurological level means the most superior level that has full motor and sensory bilaterally.
And that's where you have to have the 3+.
That's where you'd have to have the 3+, yes. Right? Anything below that could be an injury level. So this person's probably maybe a T10 neurological level. But their injury level is L3 because L3 is what helps control the knee. Right? But why can this patient walk if they're having problems controlling the knee? Because what have we given them? An orthotic. The orthotic's controlling the knee, not the muscle. The KAFO is controlling the knee. Right? So if we took that KAFO out, is that patient walking? No, because every time we stand them up, they're going down because they've only got 2+ out of 5 on the quad strength because they can't resist gravity. They have no eccentric control. Right? And 3+, and the reason we say 3 or 3+ out of 5 is what we want is because that leads to eccentric control. That means we can resist gravity. Even at a 3+, though, is the patient really going to be able to stand 100% on their own? No, because now we've added gravity plus also what? Body weight.
How do you know to give them an AFO or a KAFO? Because it seems to...
Well, it just depends upon where the injury level is. So L3, where they're lacking knee control, so we want a knee add-on to it, right? If we're down further, right, we're down L4, L5, or S's, we probably just want an AFO, because they've got knee control then, because L3's there. Right, so it all depends. What if I'm up in the T's? Now what do I want? HKAFO, right? I'm going to add some hip to it, right? And if I go up even higher in a T5, now I want, maybe, or I want a reciprocating orthosis. The THKAFOs, the thoracic, hip, knee, ankle, foot orthosis, which is that, have you guys seen a reciprocating orthosis yet? It's basically a piece where the therapist stands behind them and it's got little handles and it'll help move them forward as they walk. And it can help with the caregiver because the caregiver then can get them out of bed and get them from the bed. Maybe they're in a room where the wheelchair won't fit. they can put this big harness on them, get them up and get them walking over to the wheelchair, or maybe in the hallway, right? So it just depends on where the level is and what muscle control. And that's just a dermatome issue. Just know if I've got functional quads, I probably only need an ankle orthosis.
Oh, I guess wrong every time. So I don't
That's okay. Guessing is part of it.
And like the
Right.
arms, can they do the
Can they propel?
yeah. Like, oh, but they don't have triceps. It doesn't matter, they can still propel. Okay.
Which reminds me,
Yes?
so.
Which reminds me.
So wheelchair, right? They
Yeah.
have a, no, I lost the words. When do we adjust the depth? If they have fibular,
Oh, you mean
yeah,
the wheels forward or
or
back?
back, yeah.
Okay.
It's one of the questions.
Oh, yeah, I remember that one.
I'm like,
I think if you're a transfemoral,
femoral,
Okay.
you wanna have them further forward so you don't have to reach back so far, right?
Yep. Yeah, transfemoral, you want them a little bit more forward, because think about it. If you lean farther forward to get it, you have nothing to counterbalance you. Whereas if you're
So you have-
transtibial, you have the transtibia there to kind of resist that kind of forward motion. It's a little easier.
so you want the wheelchair deeper then.
But you want deeper back, the wheels further forward. The main thing is the wheels.
Okay.
Oh, I was like, wait, is Siri answering the question for me?
It's me, is answering the question for you.
So then the core stuff is just memorization.
Yeah, the anterior cord, the main one that you're going to get questions on is Brown-Séquard. So no Brown-Séquards. Because that's the most common one. Brown-Séquard, and what's the other one that we're going to encounter most? Anterior, posterior, anterior cord. Yeah. So those are the ones you're going to, but Brown-Séquard you're going to get a lot of questions on because that's shootings, stabbings, anything like that. Or partials, right? That's usually where they walk up something and end up kind of like that and end up with a spinal cord injury. So it's a hemisection of the spinal cord. So,
And then the different hemispheres of strokes.
okay.
Like really hammer that down too, or like it just
To a point,
confusing.
the main thing with that is if you know your circle of Willis, you can answer the question about any hemisphere. Honestly, you can. Because the circle of Willis, if it says it's an anterior portion of the anterior hemisphere, anterior cerebral arteries, you know, oh, that's anterior, it's up here, it feeds this part of the brain. Right? And that's why I try to beat the circle of Willis into you guys, because if you can kind of get an idea of the way the circle of Willis lays out, and you know generally where those are. Like if you get a pontine stroke, what's the problem? Probably gonna die. Or basilar or pontine stroke, because that feeds what part of the body? The brain. The brainstem. Yeah, right? So those type of strokes are the ones that, you know, when you talk about anterior inferior cerebral artery versus anterior communicating artery, then it's just knowing what part of the brain. So if it's anterior inferior, it's going to the front portion of the brain, lower on the brain. If it's anterior communicating, it's going primarily to frontal lobe. So they're going to present with, you know, impulse control. Down here, we're talking motor control a little bit, right? So it's just knowing where those feed at. It's knowing the brain. That's anatomy, unfortunately. And it's knowing that you have a brain. It's mush right now. I think you all need to take the rest of the day off. I really do.
Students take my exam.
What'd you say?
Students take my, today I gotta have.
Oh yeah, take the exam today.
exam.
All right. Is there anything else I can answer? I mean, you guys are doing okay. You are. I'll see tomorrow how well you guys are doing, but or this weekend.
Are we okay with dermatomes and myotomes and knowing like the nerve innervation, or do we really need to know the nerve root of it?
You don't usually have to know the nerve root specifically. Dr. Chitelli taught you that so it helped you learn dermatomes and myotomes. Like going that, you know, biceps are innervated by which muscle? What muscle, what nerve though? Musculocutaneous, which has a nerve root of C5, C6. That's what she's kind of talking about. If you know the nerve root, yeah. Yeah, they're not going to specifically ask you about musculocutaneous nerve. They're going to ask you more dermatomes and myotomes type stuff.
They have
You know?
said axillary.
Yeah, axillary is a common one. Why?
And long thoracic.
Yeah.
Yeah. Why do you think axillary is a common one? Hanging on crutches, right? And sciatic's another one because it's a common treatment. And you know, it's just the way they are. So, what else?
It's the lower extremity, I feel like it's, upper extremity I'm not that bad, still, but the lower extremity I feel like I didn't really, like, they didn't sink in.
They didn't sink in?
No.
So just go back and look at them. Go back and look at Dr. Chitelli gave you a really good chart for dermatomes and myotomes. So just go back and look at those. You know, they're in here too, but I really like the stuff he gives you because I think it's a little bit more applicable to what we do. Meds I was planning for the next trip because there's more people that are in cardio after this. So the meds are what we're going to cover next. I have that on the list for next time.
What about hypocalcemia, all that?
Yeah, that's part of the meds. We'll talk about that. Yeah, I'll talk about hypocalcemia versus hyperkalemia and all those.
Yeah, I'm like all hyper and hypo now.
Well, that's because those are specific to the meds. Certain drugs will trigger hyperkalemia, hypokalemia, hyponatremia, hypernatremia, right?
All those hypos, I'm like.
Right now, with all that stuff in the back, we're all going to have hypernatremia. Sodium, yeah, there we go, good. Anything else that I can answer that might help out? Sam, do you have anything that we didn't cover? You're good? Okay. I wasn't sure if you're frozen there because you're kind of quiet.
Solid. Yeah,
He freezes a little bit.
What's up, Sam?
You guys okay? So this help a little bit?
Yeah.
Okay. So that means that you guys need to tell the rest of your class the next time we have this, they need to come in. Oh, well, let's see how many we had here. 6, 3, 4, 6. We had more than I expected. I said 12 people were showing up. We had 10. That's 11 counting Sam. And then, well, actually 12 counting Paige. So we actually will have all 12 of you guys that said you were coming to show up. So that's pretty impressive. Paige couldn't because she's actually at work already. So
She's working now?
yeah, she's working. So I had to record it for her, and hopefully this works. And I will post this for you guys then.
Are you gonna send it to us?
Yeah, I'll post it.
Or post it?
I won't post it till I get home because I want to use like my gigabit connection to post the video versus the connection here. Because otherwise here it'll be like, I'm going to be here for a few years. Anything else, guys? How you feeling? Nervous?
Yeah.
Good. It'll get there. Alright? Go get some pizza before you go. Enjoy the rest of your day. You guys got it. I have faith in all of you. And if I don't have faith in all of you, I'll tell you after your tests. No, you guys got this.
Okay.
Alright. Sam! See you later.